Usually, when we think about engineering and design, we picture something like a bridge.
Right. Or maybe, the inside of a jet engine.
Yeah, exactly. Because everything in those environments is rigid, predictable, and well built to exact specifications. You put a bolt in a hole and it stays there.
Right. The physics in those scenarios are um, entirely mathematically predictable before you even break ground. I mean, you're dealing with static materials.
Steel, concrete, titanium.
Exactly. They don't just change their properties on a whim.
But, and this is what we're getting into today, when you step into the world of medicine, specifically the interior of the human body, that rigid engineering mindset hits a massive wall.
Oh, absolutely. We're looking at a physical landscape that is intensely dynamic.
It shifts, it breathes, it has a pulse, and most importantly for our discussion today, it collapses.
Yeah, it's the absolute definition of a nonlinear environment. And when a clinician is, trying to navigate that space, traditional static tools often fall completely short.
They just don't cut it for highly targeted procedures. So welcome to today's deep dive. We are exploring a fascinating intersection of human anatomy and mechanical engineering today.
We really are. We're looking at how exactly doctors achieve clear, reliable visibility in a confined, constantly shifting area of the body.
Right, and today's mission is to explore the mechanical ingenuity behind a specific cosmetic gynecology procedure, which is the G-shot.
And we're going to figure out how clinicians use highly specialized curved speculums and retractors to overcome the intense physical challenge of collapsing tissue.
Just to maintain a clear view of the anterior vaginal wall, which is not easy.
Not at all. And today we're pulling from a pretty wild stack of sources. We've got clinical manuals, mechanical patents, medical device catalogs.
Like Cooper Surgical and Salon Surgicare, right?
Exactly. And even a very candid consumer says blog. We're using all of this to figure out how doctors engineer their way through this environment.
And I want to say, even if you never set foot in a gynecology clinic, the spatial problem solving here is incredible. It fundamentally changes how you look at those seemingly simple tools sitting on a doctor's tray.
It really turns what sounds like a basic injection into this marvel of targeted, real-time engineering.
It really does. So to understand why these specialized tools are even needed, we kind of have to establish the stakes. What is the clinician actually trying to accomplish with the G-shot?
So the G-shot, as detailed by the clinical protocols in our sources, is a minimally invasive cosmetic procedure.
Okay.
The objective is to inject a human-engineered collagen or a highly dense hyaluronic acid directly into the G-spot.
And that's similar to like the dermal fillers used in facial aesthetics, right?
Exactly the same concept. And the purpose is to temporarily augment its size and sensitivity. Now, the injection itself takes less than 8 seconds to perform.
Which is crazy. 8 seconds sounds like a total breeze. Like you walk in, the doctor pushes a syringe, and you walk out.
Right, but pushing the syringe is the easy part. Finding the target, isolating it, and keeping it completely immobilized in your field of view, that is the monumental challenge.
Because it's super specific.
Highly specific. The clinician is aiming for a small zone located on the anterior or front vaginal wall.
Right.
It's located roughly 2 to 6 centimeters inside the vaginal opening, situated right along the course of the urethra.
And those coordinates highlight the immense risk involved here because the clinician is dealing with this dense, viscous hyaluronic acid.
Yeah, you really don't want to mess that up.
Exactly. If they miss the target by even a fraction of an inch because their view was obscured, they aren't just putting filler in the wrong spot.
Right, they risk injecting that dense material directly into or around the urethra.
Which introduces complications, severe discomfort, and just a completely botched procedure.
The margin for error is essentially zero. They need absolute visual clarity for those crucial 8 seconds. But the vaginal canal is not some rigid, hollow tube like a PVC pipe.
Right, it's not pre-open.
Exactly. It is what anatomists call a potential space.
And our sources include a perfectly vivid, non-clinical description of this from the Girly Juice blog.
Oh, I love this part.
Yeah, the writer actually purchased a medical-grade steel speculum just to explore her own anatomy. And she describes the inside of the vagina as an underground cave made of cotton candy.
Which is, surprisingly, a highly accurate biomechanical assessment.
It really is.
It highlights the softness, the mucosal texture, and most importantly, the fact that the walls naturally rest against each other.
Right, because of gravity.
Gravity and surrounding internal pressure means the space is perpetually collapsed until something actively forces it open.
So we reviewed a study from PLOS, one that dives deep into this exact spatial dilemma. They analyze standard medical tools like the Graves or Peterson speculums.
Yeah, those are the standard two-blade metal tools you'd see during a routine pelvic exam.
Right. And a standard speculum basically operates on a simple hinge, right?
Exactly. The clinician inserts it and opens the upper and lower blades, which successfully retract the anterior and posterior walls. Basically, they push the ceiling up and the floor down.
But there's a problem there.
A huge problem. Here is the critical biomechanical failure point for a highly targeted procedure. Those two blades do absolutely nothing to stop the lateral walls, the side walls, from bulging or collapsing inward.
Into that empty space between the blades.
Exactly.
So using a standard speculum is basically like trying to pitch a tent by only pushing up the front and back doors. You have the main poles up, but the side canvas just keeps blowing in and blocking your view.
That's a perfect analogy. And the PLOS-1 study specifically notes that this lateral wall collapse can be significant enough to completely obscure the anterior wall.
Oh, wow. So you literally can't see the target at all.
Right. And this becomes exceptionally challenging in patients with a higher BMI. From a physics standpoint, increased intra-abdominal and pelvic pressure forces the surrounding lateral adipose and mucosal tissue directly into the void.
The void created by the speculum blades.
Right. The higher the surrounding pressure, the more aggressively those sidewalls cave in.
So if you are a doctor holding a syringe of dense filler, trying to hit a 2-centimeter target on that anterior wall, you absolutely cannot have the sidewalls caving in and blocking your line of sight.
You can't just guess where the target is.
No. You need a localized map of the territory and a mechanical way to hold that territory open.
And this is where the clinical technique used to bridge the gap between human anatomy and the cold steel of the instrument gets really fascinating.
Yeah, tell us about the protocols from Dr. Miklos and Moore.
So they run a specialized clinic in this field. And according to their protocols, the procedure doesn't actually begin with the speculum.
Wait, it doesn't?
No, it begins with a manual tactile pelvic exam. The doctor physically uses their fingers to locate the patient's G-spot.
Oh, I see. And they often rely on the patient's real-time feedback for that, right? Because the exact depth and location vary so much from person to person.
Immensely. It could be 2 centimeters in or it could be 6.
Okay, so once they establish that tactile landmark, they possess the physical coordinates.
Right. But the engineering challenge becomes transferring those organic temporary coordinates onto a rigid tool.
How do they do that?
They literally measure the exact depth and angle on their fingers, and they transfer those measurements directly onto a specially designed curved speculum.
Which is often described in these clinics as a duckbill shape.
Exactly. They literally draw a physical map on the metal. This becomes what they call the tagged speculum.
That's wild. By mapping the target location onto its surface, the tool stops being just a generic retractor. It becomes a customized targeting system.
Exactly. When they insert it, the map on the blade aligns with the anatomy, isolating the exact agreed-upon location on that anterior wall.
I have to pause here, though, because the mechanics of this seem so precarious.
How so?
Well, you measure the depth on your fingers, you mark a metal tool, and then you insert that metal tool into a dynamic, shifting, highly lubricated cotton candy cave. I mean, a millimeter slip forward or backward, and the map is utterly useless.
That's a very valid point. Preventing that slippage comes down to robust mechanical locking mechanisms.
Okay, so they aren't just holding it open with their hands.
Right, the reliable speculums engineered for this, like the Sklar-Graves OB View models detailed in our catalogs, aren't just free-swinging hinges. They feature heavy-duty external lever and set screw mechanisms.
They lock the coordinates in place.
Exactly. The practitioner uses the lever to open the curved duckbill blades to the exact width needed to expose the tagged area on the anterior wall.
And
once the exposure is perfect, they torque down a set screw. This physically binds the hinge, securely locking the blades into that exact position.
so it forcibly converts a flexible, unpredictable biological environment into a rigid, mathematically controlled window for the duration of the procedure.
That is exactly what it does.
That's brilliant. And speaking of controlling that window, I want to bring up this layman's hack from the Girly Juice blog we looked at.
Oh yes, the horizontal trick.
Right. The author realized that if you insert a standard two-blade speculum sideways, like rotating at 90 degrees, it opens horizontally instead of vertically.
Which is so smart.
It is. By doing that, you immediately get direct visual and physical access to the top anterior wall where the target is located, and the blades are now actively holding back those troublesome lateral walls.
It's an incredibly intuitive workaround to the exact spatial problem the surgeons are facing. She basically applied basic geometry to biomechanics.
Right, she transformed an anterior-posterior retractor into a lateral retractor.
Exactly. It is a highly effective hack for self-exploration. However, in a clinical setting where you're performing an injection with needle, a doctor cannot always rely on just turning the primary tool sideways.
Why not?
Because doing so means you lose control over the posterior wall, which can then bulge upward.
Ah, I see. So the tent sides might be held open, but now the floor is caving in.
Exactly. A tagged speculum works flawlessly for a standard case with minimal tissue laxity. But what happens if the lateral wall collapse caused by intra-abdominal pressure is simply too severe?
Then the primary locked speculum isn't enough.
No, it's not. The clinician has to escalate their engineering response.
Right, because if the speculum is busy holding the top and bottom, you'd physically need a second tool, something slim enough to slip inside the first one just to hold the sides back.
And right on cue, we have the heavy machinery from the Selwan Surgicare catalog.
Yes, this catalog was fascinating. They manufacture an instrument called a lateral vaginal retractor.
Right, which is a 10.50-inch piece of solid medical-grade stainless steel.
And the brilliance of this tool is its profile. It is engineered to fit entirely inside the narrow opening of a standard, already placed speculum.
So the workflow is, you deploy the primary speculum, open it, and lock the set screw. If the lateral mucosal tissues are still aggressively collapsing into your visual field,
Which blocks the shot.
right, you slide this 10.5-inch steel retractor straight through the opening of the speculum. It reaches beyond the main blades to physically push back and hold those collapsing side tissues.
Going back to our tent analogy, if the standard speculum is the main tent pole, these lateral retractors are the specialized internal scaffolding you slide inside to reinforce the sagging walls.
That's exactly it. Structural reinforcement.
You also have tools like the Sims anterior vaginal wall retractor in these catalogs, right?
Yes, the Sims retractor. It has a flat handle and a specially curved blade, designed specifically to isolate and retract the vaginal walls for enhanced exposure.
The engineering of the Sims retractor is highly specific to the anterior wall, isn't it?
Very specific. The curve of the blade is designed to cradle the anatomy, and the edges are meticulously smoothed and rounded.
Which makes sense when you are applying significant mechanical force to hold back highly sensitive vascular tissue. Sharp edges would cause lacerations.
Absolutely. The tool has to apply firm structural support without inducing trauma.
Okay, so let's visualize the actual procedure at this point.
Yeah.
You've got a locked speculum holding the top and bottom.
Okay.
You've got a lateral retractor, or maybe a Sims retractor, holding the side walls or isolating the anterior wall.
Yep.
And you finally have a clear, perfect, unwavering view of the tagged target. But there is a glaring logistical problem here.
Hey, what's that?
The human body only has two hands.
Oh, yes. That is a major problem. Holding a manual retractor like that 10.5-inch lateral retractor or the Sims requires constant applied physical pressure.
The doctor has to physically grip the handle.
Right. So if their left hand is stabilizing the primary speculum and their right hand is holding the lateral scaffolding, how on earth do they perform the actual injection?
They can't.
Exactly. Relying on a second person, like an assisting nurse, to hold a manual retractor perfectly still while the doctor operates millimeter by millimeter introduces a massive variable of human error.
I can imagine. If the nurse's hand twitches, the field of view collapses. Or worse, the metal blade bumps the syringe.
It's too risky. The clinician absolutely needs their own hands free. They require a standard two-handed surgical technique to safely handle the dense filler and the needle.
So medical engineering had to evolve beyond 19th century stainless steel to solve this, because if metal is too heavy, requires constant manual force, and occupies your hands, you have to fundamentally change the material and the mechanism.
You need something lightweight enough to stay put on its own.
Right. Which brings us to the Guardian vaginal retractor from Cooper Surgical.
This represents a massive leap forward in material science. Unlike heavy, solid metal tools, the Guardian is constructed from a lightweight medical-grade polymer.
It looks crazy. Visually, it resembles this stylized, futuristic clamp.
It really does. And looking at the design schematics, the arms of this polymer retractor are heavily contoured and textured.
And I assume that texture is the secret to making it self-retaining.
The physics of that texture are entirely responsible for its success. Vaginal mucosal tissue is naturally composed of folds, known anatomically as rugae. The contoured, microtextured arms of the Guardian polymer device are engineered to engage with these folds. It creates immense friction without puncturing or tearing the tissue.
Oh, wow.
And because the polymer is incredibly lightweight and perfectly balanced, this friction is enough to lock it in place.
So it actually leverages the body's own anatomy to anchor itself. That is so cool.
Once the clinician places the Guardian and expands the arms, it stays exactly where they put it. It provides exceptional lateral retraction, completely neutralizing the tissue collapse.
And most importantly, freeing up the doctor's hands completely.
Exactly. Cooper Surgical's catalog explicitly notes this facilitates a two-handed technique, which drastically reduces the risk of needle sticks.
Which is vital. When you are injecting highly pressurized hyaluronic acid into a microscopic target, you literally cannot afford a slip just because a heavy steel retractor shifted in a nurse's grip.
You really can't. The amount of engineering dedicated just to securing a clear line of sight for an 8-second injection is staggering.
It really is.
But the patent filings in our stack of sources show that biomechanical engineers are pushing the boundaries even further. They are moving far beyond simple plastic friction clamps.
Right, and patent US 6379299B1 is a perfect example of this evolution because, we tend to think of speculums as these archaic, unchanging devices that just haven't evolved in a century.
A lot of people think that.
But this patent proves that engineers are literally creating devices that let doctors dial in their exposure. It outlines a highly advanced speculum engineered with independently adjustable sliding blades.
And the mechanics of this device solve one of the most frustrating aspects of localized observation.
How so?
Well, with a standard duckbill speculum, if you want to clearly observe just one specific section of the wall, you often have to remove the entire device, take it apart, and reinsert a single blade to press against the tissue.
Oh, which completely destroys your carefully mapped coordinates, and it's incredibly uncomfortable for the patient.
Exactly. But this patented device has independently sliding blades featuring a built-in measurement scale.
It's literally a ruler permanently etched into the sliding components.
Right. The patent details that this ruler is referenced against the hymeneal line.
For context for you listening, the hymeneal line is the ring of tissue located at the vaginal opening.
Yes. And in this engineered design, that anatomical landmark acts as absolute zero.
So, by using the hymeneal line as a 0 point, a doctor can insert the device and retract just one of the blades halfway down the ruler,
while leaving the other blade perfectly in place to provide structural support.
Wow. It basically allows the clinician to expose a very specific section of the vaginal wall, such as the exact coordinates on the anterior wall needed for a G-shot, without sacrificing the structural integrity of the entire space.
You don't have to remove the tool and start the mapping process all over again.
It operates like a window where you can just, slide individual panes of glass out of the way, depending on what you want to look at.
That's a great way to put it.
And the patent also details a ratchet system, right? It features a trigger with interlocking teeth.
Yeah, as the clinician pulls the trigger to slide the blade, it physically clicks and locks into place millimeter by millimeter.
Which represents the ultimate evolution of the tagged speculum we discussed earlier. You don't need a doctor to manually draw a map on the metal with a marker.
Right. The tool itself is a calibrated grid. It allows the clinician to dial in the exact depth of the target anatomy without needing a separate ruler. It maintains absolute control over that dynamic environment.
Let's step back for a second and summarize this mechanical journey we've been on.
Sure.
We started with a procedure, the G-shot, that takes a few minutes in a clinic and involves an injection lasting mere seconds. It sounds incredibly simple on a brochure.
But the reality of performing it safely without injecting filler into the wrong anatomy relies on a massive symphony of mechanical problem solving.
Right. You start with the tactile mapping of a collapsed pressurized space. You transfer those coordinates to customized duckbill speculums utilizing heavy-duty screw locks to force the primary space open.
And then, when intra-abdominal pressure causes the lateral walls to cave in,
you deploy specialized 10.5-inch steel lateral retractors, or curved Sims retractors, to hold the internal scaffolding.
And finally, you integrate cutting-edge, self-retaining polymer mechanisms that grip the tissue folds alongside ratcheting slider blades.
All meticulously engineered to defeat the physics of the human body.
The knowledge we've unpacked today fundamentally changes how you should view medical hardware. The next time you see an instrument in a doctor's office or on a clinical tray, I really hope you look closer.
Yeah, don't just see a cold piece of metal or a plastic clamp.
Exactly. You are looking at a highly evolved, meticulously engineered solution to a complex, three-dimensional spatial puzzle. Every curve of the Sims retractor, every set screw, every textured polymer arm, it all exists because human tissue behaves in entirely unpredictable ways.
It is a true marvel of real-time engineering. But before we wrap up this deep dive, I want to leave you with one final provocative thought to mull over.
Okay, let's hear it.
We've spent this entire time exploring how engineers design sliding blades, built-in rulers, and self-retaining polymer scaffolds for one singular purpose: holding the body open wide enough so the human eye can get a direct line of sight from the outside in.
Right. The entire history of these tools is based on the quest to widen the visual field.
But there's a second patent in our stack of sources today, patent US 1068894B2. And this document hints at a completely different engineering paradigm.
Oh, this one is fascinating.
It is, because if we are working this incredibly hard just to physically pry a line of sight open against the forces of the human body, how long until physical retractors become entirely obsolete?
The mechanics detailed in that patent change the approach from the ground up. It doesn't rely on sliding metal blades or expanding plastic arms at all.
No, it outlines incorporating optical fibers and endoscopic imaging channels directly into the inner structure of a very slim device.
Instead of fighting tissue pressure to open the body wide enough for the clinician to look inside,
the future of this kind of medicine might not rely on widening the view for the human eye at all. Instead, we are bringing a digital eye directly to the tissue.
the tool itself becomes the camera.
Exactly. You don't need a massive, locked retractor to hold the walls open if a tiny fiber optic lens is already resting millimeters away from the target on the anterior wall.
It completely bypasses the spatial dilemma entirely. The ultimate engineering solution might just be to stop fighting the anatomy with heavy metal scaffolding and simply bring the light inside.
It's wild to think about. Keep questioning the design of the world around you, and we'll catch you on the next deep dive.